What is the current state of value-based care, and what are some examples of value-based care? All right, so let me just start this video with a disclaimer. This is going to be less than half-baked. It's very informal, and I'm just going to rely on some websites, and that's because my knowledge of this topic is fairly low, and I've only spent an hour or two preparing for this. Having said that, I still think there's value. So I'm an emergency physician. I'm on a journey to understand and transform our health system. And I'm producing these daily videos because I think a bird's eye perspective to our health and healthcare systems is crucial. I think we need transformational change. So what I'm trying to do is every day get enough of an understanding of a topic to understand how it fits into other topics, health economics, health education, the history of health, et cetera, and then share what I'm learning. So for me, it's a journey. I encourage you to confirm anything that I say today, but I will provide links to everything that I provide. So a bit of a history. So the managed care era was in the 1970s and 1980s, and they focused on cost control and care coordination. These organizations introduced concepts of preventative care and emphasized the importance of primary care providers. Then in the 1990s, there was a bit of a backlash against managed care. There were managed care organizations that were set up for profit, and the Institute of Medicine came out with a number of reports. To Err is Human is one of those that focused on the need for improved quality in healthcare. Then value-based purchasing came in the early 2000s. And then the Affordable Care Act in 2010, which produced comprehensive reforms. There were a number of different provisions within it, established accountable care organizations, bundle payments, and the hospital readmissions reduction program. So essentially, over time, we've had a number of programs, and now MACRA and the Quality Payment Program in 2015. And I'll talk in brief detail about each of those in just a minute. But a bird's eye view is that fee for service, so the payment of a healthcare provider, physicians, nurse practitioners, et cetera, others, for an episode of care. So you go to the doctor, you pay for that episode of care, regardless of whether you get better, regardless of what happened before that episode, regardless of what happened after that episode. You pay because you participated in that episode of care. So that fee-for-service has dominated our healthcare system and continues to dominate our healthcare system, despite attempts over the years to shift more to value as opposed to volume. All right, let's move to this next website. This is from the American Medical Association. I'd just like to share briefly here. They discuss, I guess, six characteristics of value-based care that in an ideal world provide value or are reasons to adopt this approach. One is quality over quantity. Another is patient-centered care. Another is enhanced care coordination. Another is increased data access and analytics. Another is better affordable care. And finally, digitally enabled delivery and continuous learning. So those are all theoretic and idealistic. So if in an ideal world, a shift to value-based care would include those characteristics. Now let me just scroll down a little bit here, and it lists a few examples of healthcare systems that are incorporating these ideas. Bay Health. At Bay Health, value-based care helps out the patient first. At Geisinger, Henry Health, the Permanente Medical Group, and Virginia Mason Franciscan Health. At Henry Ford Health, value-based care work leads to health improvement in Michigan. At Previa Health, bridging value-based care to the youngest patients. And finally, Stanford Health. So these are examples of where the AMA suggests that successful models for value-based care are being implemented. Now, my experience in my reading is that to some degree, value-based care is being implemented everywhere. And yet what I'll continue repeating is it seems to me that fee-for-service is still the dominant paradigm. All right. So now this is a state legislature website that I felt this table was helpful. So this table describes different types of payment models for healthcare providers. So if you can imagine, on one extreme is fee-for-service, which means the payer pays the healthcare professional regardless of the quality, in theory, regardless of the quality of the outcome. They're just paid for each service. On the other extreme, a healthcare provider could be on salary. So they get paid based on the number of hours that they work or the days that they work, regardless of the volume. And then there's a number of different schemes in between. And one would be an accountable care organization. So they are groups of clinicians, hospitals, or other healthcare providers that come together voluntarily to deliver coordinated, person-centered, high-quality care to a population of patients. They may or may not be organized as an independent legal entity and led by physicians or a hospital or health system. So two examples here are the Idaho Healthy Connections Value Care Program and the Vermont All-Payer ACO model. All right, next is bundled payments or episode-based payments or episode of care payments. So bundled payments is essentially the payer pays a set amount for a particular diagnosis or procedure. So for example, if a patient needs a hip replacement, there might be a specific payment for the hip replacement, regardless of how many visits prior to the surgery, after the surgery, regardless of how many complications there are from the surgery. So in theory, the healthcare providers would be incentivized to minimize complications, to minimize lengthy stays, and would be incentivized, again in theory, to provide efficient care. All right, third is capitated primary care payments. So this is a type of population-based payment in which primary care physicians are paid a fixed fee for a duration of time per member, usually per member per month. So if you can imagine, for every patient that is cared for by this primary care provider, that primary care provider gets paid a certain amount each month, and then they care for that patient. So whether that patient comes in every day or whether they are given text messages or education or whatever the care is, they get paid a certain amount. And so in theory, under this model, the providers would be incentivized to focus on preventative care, especially short-term preventative care, so that the patients don't come back more, which could happen in a fee-for-service model where the providers are paid for more visits. Finally, there are global budgets or global payments, and that's a type of population-based payment in which predetermined payment amounts are made to a group of providers or a health system covering most or all of a patient's care across providers during a specified time period. So this might be an entire hospital system or an entire state. So I didn't give the example. So there are examples of each of these, of bundle payments and capitated primary care payments over here. And again, I'll give these links in the description. So I know that Maryland has been involved in these global budgets, payments, and my understanding is that a payer will provide the health system, which could include surgery centers, hospitals, clinics, physicians, nurses, respiratory therapists, et cetera, et cetera, et cetera. So an entire healthcare system, a budgeted amount for maybe an entire year. And so that healthcare system, in theory, ideally, would be incentivized to provide excellent care during that time period, during that year, in as efficient way as possible, preventing patients needing to come back to receive health care. And then that hospital system could, in theory, make more money based on keeping their population healthy. All right, let's go over to the next website, which just provides a glimpse into one type of value-based payments called MIPS, which is merit-based payments. So as an emergency physician, I'm actually involved in a group that's receiving these types of either penalties or bonuses. So as you may be able to see, but if not, I'll describe it. In 2017, MIPS is essentially a list of clinical outcomes or clinical approaches. So for example, it might be, does this patient with a specific injury need to get a CAT scan? Or are antibiotics indicated for a specific condition? And so these are evidence-based. In theory, they're strong, have a strong evidence base for particular interventions in medicine. And if healthcare providers, physicians and physicians associates, et cetera, meet certain benchmarks, then they either get a certain percentage of bonus or a certain percentage of penalties. And we're now in 2024. It doesn't even have it here, but up to 2022, the penalties were about 9%, and the bonuses were about 9% as well. And I think that's 9% of, I want to say Medicare payments, but I'm not entirely sure. All right. So here's an article in Medical Economics of the State of Value-Based Care, published in June of 2024. I think it's interesting to note that 70% of Medicare Advantage enrollees opted for value-based care providers. As I recall, I think 60% of providers nationwide are involved in some level of value-based care. And that's changing very quickly. So it says here that there's been a 25% increase in healthcare provider participation in 1 year. So this is a very dynamic landscape that's changing literally day to day. And then finally, this is an article that highlights some reluctance. So why primary care practitioners aren't joining value-based payment models, reasons and potential solutions. So this goes into reluctance such as it seems idealistic or overly ambitious to participate in these. They're often marketed as helping to improve the quality of care and save money, though they can't improve quality without more resources, so the need for additional resources, et cetera. All right, I'd appreciate your comments, criticism. I'm happy to dive into this in more detail, provide a more rigorous overview, although again, I'm focused on health and well-being for all at the lowest possible cost to the system for our entire nation. So I'll be diving into a number of topics. Appreciate your comments, questions, and criticism. Thank you.